work in progress, and for a country of our size, a lot of thing takes time to kind of address that. But yes, when we take it on priority, we have also been able to kind of turn the tides really well in our healthcare system. Uh, Let me go to Dr. Madan Gopal also in this aspect. Dr. Madan Gopal, Urvashi ji also mentioned about that, work is being done, and the health system at the ground level, at the grassroots level is being strengthened. How you look at it, and do you also see that we are, kind of provisioning enough when it comes to addressing problems like this, and especially because that also, apart from the nutritional aspect, apart from the initial care aspect, our healthcare system is largely skewed towards and especially for women, towards the reproductive phase of their life. So are we really taking a life course approach when it comes to women health, and we are provisioning enough, or do you see that there is a lot more to be done to address the relatively complicated symptoms like higher number of hysterectomies?
Kamalji, thank you. It's a very complex question, but I will give
the topic is complex.
Don't worry about that, because as Manoj has pointed out, it has to be both the sides, I think demand as well as from the provider side. Because when I was involved in the insurance program, RSP5, at that time, quick empowerment has happened, and we have seen spurt of hysterectomies. Same with Arogyasri and that kind of insurance schemes. That means there was demand of the people. The demand was there. And as he has rightly pointed out, people come at very late stage. And they come and say demand because of fears. And the providers have no choice but to at least see that how to cater to the needs and other things. Though other things are there, but you see the category of the people who are availing hysterectomies. It's all the people who are in the rural areas and the other peripheries. So you have to just do more deeper analysis to understand the problem. It's not only medical problem, but it's a social problem as well. Because it's a wage loss is there. Yesterday, one person of the grant miner, he was saying that the wages, if their wages are paid on time, then they are very happy with that. That's the only thing which strikes. If a woman having, because dysfunctional uterine bleeding is one of the leading cause for indication for hysterectomies. If you look at that, how to prevent DUBs, you have to investigate more deeper into the DUBs to understand the plethora of the problems that the woman faces because of DUB. It's not only one. It's very cumbersome. Can she buy, if she is having heavy menses, can she buy, and are we able to provide adequate sanitary pads? Or she is just relying on the traditional old clothes and other things. So as a result, what happened, the peers, they say that you go and get rid of that. That was the thing, because I went as a part of the central team way back in 2013-14 when the investigation of hysterectomies were done in 3 states. Then when we contacted the people representative, they asked that what is the age of the mother who underwent hysterectomy? How old is the last son? These are the 2 questions which the people representative they asked. And we told that most of the cases the youngest child is 10 years, what they should have. That kind of perception is there in the community, and they are the influencers. And that's one thing. I'm just adding to what Manoj has mentioned, that these are the challenges which we have to address when we want to preserve the uterus. Second thing is not only we would be tempted to say that the government programs are more or less towards the reproductive and child health. No, it's not like that. You think at the evolution of the programs. We started with family planning way back in 50s. Then it became a family welfare program. Then we had the RCH, reproductive child health program. Then reproductive child health program. It was further elaborated, and the National Rural Health Mission was launched. After the National Rural Health Mission in 13-14, it became National Health Mission. That means in a mission mode we are trying to do this. And one of the component of this NHL program is your RMNCH, that is reproductive maternal newborn care, plus adolescence. That means a life cycle approach has been envisaged. It's not only reproductive health, we are connecting the reproductive health to the maternal health to the reproductive health. NFHS 5 has mentioned about how the efforts of the government have yielded that we have been able to reduce the maternal mortality ratio. We have seen that all the women they are coming to the institutions for a safe delivery. Even if a home delivery is happening, that is happening through a stillbirth attendant. That kind of things have been put in place. That's one thing. Second thing, we are trying to link the adolescents with the reproductive care also. Plus, the best element, that is the life, in the life cycle, the person has to has his family. So family planning is also linked with the maternal services. So that the cycle approach is there. Apart from that, we are connecting the women and the community with the communities through the linkages programs. You have the voluntary of your ASHA workers who are giving the outreach services. You are having the auxiliary nurse midwife at the nearest population. Similar kind of replica has happened in the urban areas. Apart from that, we are having a Suman program at the national level. That means selection pathway Ashwashan. We are giving an assurance that the women would be having a safe motherhood. Previously, it used to be child survival and safe mother. Now we are giving a guarantee. That means if anybody coming to the government institution, these kind of things would be there. The dignity of the woman will be maintained. The safe delivery, privacy of the persons would be maintained. And any complaint is there, any grievance is there is zero tolerance for any grievance. That kind of assurance has been given. That's one thing. Apart from that, for hysterectomies and C-sections, we do have guidelines as Nirmal ji has mentioned. In the government sector, any hysterectomies which are happening, they are all audited. And if a hysterectomy is indicated, then some permissions and protocols are there. And we have wrote in the Federation of Offset Dining. Also, they are also given guidelines to the fellow members that any hysterectomy that needs to be audited, whether it is indicated or not. Similarly with the C-section. That kind of mechanism is in place. Now it's only the thing we have to see that how we monitor that. These kind of all things are in place. That means instead of just focusing on the maternal and child health, we are focusing on a life care approach to the RNC program. This talks about right from the adolescence, connecting and extending the community level linkages, as well as how to bring them, the women to the Arogya Mandirs, that is the erstwhile and the wellness centers. We are trying to see that how a linkage is built so that a cycle approach is there for addressing all the healthcare needs of the women.
So wonderful, sir. This is actually the work which has been done by the governments has been remarkable and has been appreciated, I think, at all level. Especially you mentioned about reducing the maternal mortality rate and other aspects. And absolutely, the approach is getting wider, as you highlighting. But at the same time, we also need to see a few issues which are coming out of either because of the past baggage, or maybe the kind of lack of compliance to the new systems. Let me go to Dr. Rakesh Gupta at this moment. Dr. Gupta, I kept you for the last because you are coming from a state which is having the maximum population in our country, and also you are heading a large government setup. Interestingly, Manojji talked about the Kerala numbers there. The prevalence of hysterectomies in government-private setup is 60-40. For 60 in private and 40 in government, which is quite in a way at par. But in your state, it is around 25-75. So the government setups is doing 25% of hysterectomies, while 75% is happening in the private sector. How do you see this situation? Again, my question is that how come many of the people working in a private setup are reaching in a situation where they need to go for hysterectomies? Apparently, 3 out of 4, because that's how the 75% if I can decipher. And while when they are working in a government setup, it is just 1 out of 4. So how do you look at this problem, and where do you see that if these both arms can at least come relatively at par, or collaborate better, which is also the one of the solution we are exploring, which is public-private partnership.
Thank you, sir. Thank you, Kamalji. And thank you, IHC, for inviting James. And since this is a very important topic, and our commitment of James, not only me, my faculty, residents, and students of MBBS also are here in the auditorium. See, we have seen a lot of views, and though national average is 3.3%, some states, as you mentioned, is 8 to 10%, which is a huge number. And more than 50% of these hysterectomies, they are actually avoidable.
So can you repeat this once?
See, on an average, 3%, 3.3% is the national average. Some states are doing even 8 to 10%. I need not to mention the name. Some are even, best of the state, which is 0.8 or 0.7%, Sikkim and Meghalaya, so they are much less. UP figures around 2.6%, so less than the national average, which is actually required. And more than 50% of indication, if you analyze all the cases of hysterectomy, these are preventable causes. So we can definitely put a stop there.
So 50% of hysterectomies
Yeah.
can be prevented. Or
Yeah, not all, but because government setup, we have no other incentive, but it is a patient's indication which actually we are doing it. So more than 50% can be actually avoided. Now we have to go a little more rooted causes why actually it is being. There are multiple factors from patient side, from doctors, from hospital side, and more than 70%, as you said, is a private sector, right? So there are multiple factors which we need to analyze, and since we have got from advocacy, from government, from private, everyone is here. This is the right platform, not to criticize anyone, but yes, we have to analyze the cause in the interest of the patient, poor patients, needy patients, how we can actually make policies which is actually beneficial to them. So regarding patient side, actually there is a lack of education, there is lack of awareness. And if you see NHFS 4 and 5, the root cause is a poor menstrual hygiene. And there is definitely increase from 58% to 70%.